Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers. Today, Ozempic and the new obesity medications. Dr. Samir Khan is a fellow in gastroenterology at Johns Hopkins. He gives Dr. Josh Sharfstein a tutorial on what these medicines are, how they work, what questions are not yet answered, and how hard it can be to obtain them. Let's listen.
Dr. Samir Khan, thank you so much for coming to Public Health on Call to talk about these new medicines that treat obesity.
Thanks, Josh. It's my pleasure. I'm excited to talk about them.
So let's just start with the basics. What are these new medicines and how do they work?
Okay, great. So the ones people have probably been hearing the most about are Ozempic and Wegovy. So the pharmaceutical name for these two medicines is semaglutide, and this has been plastered all over the news for the past 2 years. And then the one that people, especially diabetics right now, are starting to hear more about is something called Mounjaro, which goes by the name of tirzepatide. In terms of how they work, that's one of the core questions because we're still figuring some of that out. We know how they work in terms of diabetes because they help our pancreas make insulin after we've eaten and our sugar levels start rising. And we know that it helps to also reduce a hormone that causes sugar levels to rise in the bloodstream. But we're still working on our understanding of how it works on our appetite specifically.
So these medicines, through some not totally worked out mechanism, make people less hungry. And then what happens?
Yeah, so that's exactly right, Josh. And so for instance, we know these medicines have a receptor in the brain. We know that receptor is in the hypothalamus, and we know that regulates our appetite. But our scientists haven't figured out the precise mechanism for the way that these medicines do that. And I think that's highlighted some of the concerns you're also hearing in editorials in the news coverage for these medicines, which is that we haven't ironed out what these medicines do exactly. And so there is some concern from some health experts related to that.
So let's talk about the benefits and the risks. So in terms of the benefits that we know so far, what's on that list?
So the first benefit we know about is that it helps to get your sugar levels down. It helps your body make insulin. And if you're a diabetic, these medicines can go a long way to helping you control your sugar long term. So that's probably one of the first big ones. And then the second one that we've sort of figured out by mistake and then realized it was very effective for is that it helps to achieve weight loss. And the big studies coming out are telling us that over about a year and a half, people are achieving about 15 to 20% weight loss.
And that's a lot.
That's a lot. I think, Josh, the one thing I'll add just to give you perspective, if a patient 15 years ago went to a bariatric surgeon who is offering a surgical sleeve gastrectomy, which is when they tunnel off and make the stomach look like a little pouch, that would on average achieve somewhere between 15 to 20% weight loss after a year and a half. And so this is pretty profound.
So talk to me about the potential risks, the side effects, and some of these outstanding questions.
Yeah, so this is where my role as a gastroenterologist really kicks in, Josh. So we have a lot of patients talk about nausea, something like 50 to, the data supports this, something like 50 to 60% of patients will experience some nausea. Many of them will tell you that it gets better if they're able to sort of stick to it and endure. And one of the funny anecdotes you'll hear from some of my gastroenterology colleagues is they'll say, we've had issues where a patient was supposed to get an upper endoscopy, hasn't had a meal since last night, but we go into their stomach and they've still got some food in there. And we think it's their Ozempic that's causing their stomach to slow down. And now we're asking them to not eat anything starting at lunch or hold their Ozempic for a whole week.
Start not eating sooner. So for this procedure, the doctors can have an empty stomach to look at.
Yeah, that's exactly right. The endoscopy at center at Johns Hopkins has started a general recommendation to our patients where we ask them to hold a single injection of this medicine the week they're going to get their endoscopy procedure, because we're actually seeing this enough.
Dr. Khan, I think I'm getting the point that these medicines may work by slowing the passage of food through the digestive system. But I don't quite understand why that's a funny story.
Well, I think for those of us who do endoscopies, what we've discovered in the last several months is we go in to do an upper endoscopy. The patient swears they haven't had anything since dinner last night, and we go in and the stomach is full with food. And we have to immediately abandon the procedure. And so you have a crowd of angry gastroenterologists trying to deal with these full stomachs. And it's just been a learning process for us with a lot of frustration and raised eyebrows when we realize a patient's taking Ozempic and we're getting ready to do their upper endoscopy.
I think I can buy that a crowd of angry gastroenterologists could be funny. So thank you. So besides nausea, what else is on the list of concerns for patients?
So I would say overall, these GI side effects are amongst the most common. So there's nausea, there's vomiting. A good percentage of patients, maybe somewhere between 10 to 20%, also describe diarrhea. And then, Josh, I think something important to highlight is some of the earlier studies, there was some concern for pancreatitis, that the pancreas was getting inflamed and that this was a potentially serious adverse effect. I will say that over time, we think that happens a lot less than we previously thought. And that's because we're getting 4 to 5 studies every year at this point on these medicines or related medicines. So globally, our understanding of what's happening is improving. And then there's also a risk been described for something called medullary thyroid cancer, which is unusual. And often people have a family history of some kind or some kind of genetic predisposition for this cancer. And it seems to be uncommon, but many prescribers will withhold from offering this medicine if patients have a personal history or sometimes a family history.
You mentioned that some experts have some other concerns about these medicines, perhaps more fundamental concerns. What are those?
I think the big one is everything we know about these medicines suggests you can't stop them. And so all of our trials, one of the longest trials I have on these medicines is about 72 weeks. These are the big studies that are coming out. There's something coming hot off the press that will be 5 years. But the point is this: if you're going to have people on a medicine that we're still ironing out how it works, and they might be on it for their lifetime, we need to be able to tell doctors and the patients they're prescribing this to what the long-term consequences of prescribing these medicines are. And given that we can't describe for you what this medicine's doing on the receptors that are in the heart, or people's muscles, or sometimes their fat tissue, there's a lot of folks who think we've got a lot more homework to be done before we widely start prescribing this medicine to everyone.
So you have been prescribing this medicine, it sounds like, to some patients.
Mm-hmm.
And yeah. I wonder what your experience has been.
My first experience, I would say, is that it's really tough to just get the medicine to patients. So just to give perspective, I'm a gastroenterology fellow. That overlaps with hepatology. And the reason I even bring all of that up is because the number one reason we're starting to transplant people in this country is fatty liver disease, which is directly related to obesity. It's hard to really separate the two. And so as hepatologists, we've started to ask the question, well, how do we save people from having so much fat in their liver for prolonged periods of time such that it's causing them to have end-stage liver disease? And these medicines are in our discussions. But the trouble so many of my colleagues and faculty mentors are having is getting this medicine covered by insurance, or finding a patient, even if they have something like Medicare D or some other insurance, finding that the result cost that they still have to make as a copay is far beyond what they can afford.
So the first issue is actually having patients be able to get the medicines. And you're struggling in many cases, even for patients who you think could benefit quite a bit.
That's right.
You're struggling even to get them the medicines.
Yeah, I think there's a real phobia on the provider's part of, okay, well, for every time I prescribe this medicine, I have to get on the phone with an insurance company and start talking to people just to get this covered.
Wow. And what about for when you're able to get over that hump? What's the clinical experience been?
I mean, I've had a lot of patients who have had success, and sometimes it hasn't even been myself prescribing, but I'll have a patient who has diabetes who will start these medicines, and I'll watch their insulin requirement come down by half. I've had a handful of patients, and this is particularly relevant for me from a liver enzyme standpoint, where I've seen their liver enzymes get better. And that suggests to me that not only are they starting to quote unquote look better in front of me in terms of the weight they're losing, but that weight is translating to less fat in their liver's less inflamed. And hopefully this is a sign that we're going to see liver recovery down the line. And when you're thinking about transplant big picture, that's an incredible potential outcome.
And in fact, there is some early data about the health benefits more broadly, besides obesity and even diabetes, for patients taking these medicines. Is that right?
Yeah, I think it's why I think this episode is so important. I think from the perspective of the heart, from the kidneys, and now we have addiction medicine studies looking at this medicine, we might start seeing much wider applicability of this medicine. So cardiologists and our nephrology kidney doctor colleagues have been looking at this medicine very closely. And we expect a study to come out from Novo Nordisk. This is the maker of semaglutide or Ozempic, in the next month or so, that looked at a huge group of cardiology patients. And if the preliminary results suggest that over 5 years, there was a 20% reduction. So in heart attacks, strokes, and death from a cardiovascular cause in their patients who are on this medicine. And if that's true, and that, if that evidence holds to the standard that we'd expect for a rigorous randomized control trial, it suggests to me that we're going to see this used for a lot more than just diabetes and obesity, but you're going to have physicians caring for patients for even related cardiovascular conditions, kidney conditions, start wondering if they need to start prescribing this medicine.
So that brings us to this really interesting point where, as you said, the long-term consequences of taking these medicines just aren't known because there hasn't been enough time. On the other hand, there appear to be some pretty significant short-term benefits and maybe medium-term benefits in terms of health for heart disease, kidney disease, and other conditions. So how do you think patients and doctors should balance those?
The first of these medicines is introduced all the way back in 2005. It's one we don't use that often anymore. It's called exenatide. But I only mention that to say this. That medicine's been in circulation for a really long time, and it was used for diabetics starting in 2005. And I think if the long-term data of how patients are doing on exenatide is any clue, then we at least have about 15, 16 years of at least practice-driven knowledge about how well tolerated these medicines are. And I think it offers a little bit of a glimmer of hope to say that, okay, we think this is relatively safe long-term, but I think we've got more homework to do.
So if I come into your office, I've seen some news story about a celebrity taking Ozempic, interested in getting it. How long do you take to talk somebody through what's known and is unknown and, kind of try to get me to a point of making an informed decision?
Yeah, that's a great question. So I usually start that conversation just getting a sense of how long they've been thinking about this issue and what they've tried in the past. And this probably won't surprise you at all, Josh. A lot of these patients have tried before. That whether that's been gym memberships, recruiting family members, joining running clubs, cutting out anything after 8 p.m., trying intermittent fasting, you meet patients who tell you a lot. And so once I've sort of covered the ground of patients who've made dietary or lifestyle changes and have attempted to do that long term, I have sort of a framework to know, okay, this person's been fairly committed to this path. And once I know that, I start this conversation. And it's usually not a decision I make in a single visit, because one of the first things I tell patients is, if I stop this medicine, the weight comes back. And so I usually give patients some time to think about this before I make the decision. But that conversation is usually taking me most of the visit, so that they're informed and they feel aware of why we're trying this, and including the potential financial burden.
Let's just end with a question about that. Given what you know now, what's your perspective on the barriers that patients face getting access to these medicines?
I think if we don't have a joint effort based on policy, potentially with getting involved with partners in other countries to address the cost of these medicines, the fact that we're breaking ground for treating obesity may be a moot point. The reason I say that is currently Wegovy, one of the first medicines you and I ended up talking about, is $1,350 at list price. Now, most patients with coupons and rebates can get it down to $700 a month, which is affordable for almost no one. And there's been a lot of conversations, including in Congress, about getting, Medicare D coverage for these medicines. Are state legislatures expanding Medicaid coverage for these medicines? But the expense to our health insurance, the amount of spending that would go just to covering these medicines make it really completely untenable for even the government to sort of subsidize in this way. And so what we really need is some kind of cost-cutting measure. And I will say there are parallels that exist for this. So Wegovy and Ozempic are about a third of the cost they are in the United States and Canada. Similarly in Sweden and Norway, and they're a fraction of the cost that they are here. And so I think part of what needs to be done is how we negotiate with our pharmaceutical companies providing this medicine in conjunction with some kind of policy initiative to make sure that, the 20 to 30% of the population that might be eligible for some of these medicines actually can access them.
Dr. Samir Khan, thank you so much for joining me to talk about this very interesting development in medicine.
My pleasure, Josh.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinale, Philip Porter, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Fernandez and Shian Briscoe. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.